Okay, let's dive right in. Imagine this. It's December 19th. The phone rings. A pediatrician is calling, and well, it sounds urgent. They're talking about a tiny baby, just 2 months old, called Max. He has something called congenital nephrotic syndrome. Needs a continuous albumin infusion. And his parents, understandably, they just want a home for Christmas.
Wow.
Yeah. And that single phone call, it just drops us right into this really big challenge in pediatric healthcare.
It really does. And what's so striking right away is that contrast. You've got the parent's desire, which is completely natural, versus the very complex medical reality, congenital nephrotic syndrome. It's rare, but it's serious. Affects babies right from the start. And the cure really is a kidney transplant. Okay. But you can't do that until they're maybe 2-3 years old.
Right. So until then,
these little ones need really intensive support, lots of medical care, often long, long stays in the hospital.
So that brings us to the core question for today's deep dive. Is it actually possible to take that complex hospital-level care and successfully deliver it? Well, in Max's own home.
Yeah.
It's a huge shift we're talking about.
Yeah.
Moving from that super controlled hospital setting to, the dynamics of a family home.
It is. And when this idea first came up for Max, the reactions were, well, all over the place, weren't they?
They really were. You had some saying, absolutely not, no thank you. Others were like, great idea. And even someone saying, next week. Oh, that's easy.
Right, easy.
But the reaction that really gets to the heart of it was, oh, that sounds great, but how? How can we actually do this? Can we get more details? And that how is exactly what we're going to unpack today.
That how is everything. And it leads us straight into this concept of hospital at home, or HAH, especially when we're talking about kids. Now, the usual idea of HAH, it often centers on adults, like an acute care service instead of a hospital stay for certain illnesses. But for children, particularly kids like Max with these long-term complex conditions, it's quite a different picture.
Absolutely. It's not just managing some short-term thing. You have to think about their growth, their development. I mean, Max, at 2 months old, has totally different needs than he will as a toddler, running around with medical gear, or even older.
Exactly. Development is huge.
And here's where it gets really interesting. It's not just about keeping them medically stable. It's about supporting their healthy development, too. There's actually research suggesting that chronically ill kids who spend more time at home in that familiar environment, they often do better developmentally than kids stuck in the hospital long term.
That developmental link is so critical. Being in their own space, it can make such a difference to their emotional well-being, their learning, everything. Now, adding another layer here, Max has a rare disease. And while any one rare disease is, well, rare by definition, if you group them all together, they actually affect a lot of children.
That's a great point.
Yeah.
And a big challenge with rare diseases is often the lack of sort of standardized care plans. Because each condition can be so unique, maybe not fully understood. It makes things like outpatient referrals really tricky. There often aren't established protocols or, widespread expertise you can just tap into. So trying to fit a child with a rare disease into a standard HAH model, it definitely throws up some unique hurdles.
Which brings up a really important question. Okay, so for which kids does HAH really make the most sense? Who benefits most?
Yeah.
Generally, we're looking at patients with pretty significant medical needs. Maybe they need regular treatments, ongoing evaluations, or there's a big need for education for the child, for the family. Often these are kids who are facing, frequent hospitalizations or really long ones.
Right. And hospitals, while obviously necessary sometimes, they're not always the best place for a child's overall well-being, are they?
Not at all.
And you think about those really complex situations, too. Maybe a child needs IV meds or complex wound care that needs something like nitrous oxide for pain.
Right, which isn't always available outside the hospital.
Or maybe they're dealing with difficult social situations at home.
Yeah.
These can all be really strong drivers for considering HAH. Even things that seem routine but are continuous, like Max's albumin infusions. Managing that outside a hospital is complex.
It is. You've got dose adjustments, regular blood tests. It's not just plug and play with a pump at home.
Yeah.
And what's interesting, too, is how the local healthcare system plays a role. Like in France, they have a very established system for parenteral nutrition feeding through the veins.
Okay.
So HAH usually wouldn't be needed just for that. But if the parents couldn't manage it, if they couldn't monitor it properly, or maybe they just didn't fully grasp it, then HAH could step in to provide that essential support.
So it really depends on the local context, too.
Absolutely.
Yeah.
What other options are there? What resources does that specific area have?
Okay, so we've got a picture of the kinds of patients who might be suited for HAH. But how do you actually do it? How do you translate that hospital care into the home? It's definitely not just sending them off with a bag of supply.
No, absolutely not. The very first step, and it's critical, is a really detailed medical discussion. The hospital doctors, the HaH team, everyone needs to talk. As HaH specialists, we really have to challenge that default hospital thinking sometimes. If we're thinking about something complex, maybe invasive at home, we have to be sure, are there really no other options? Have we explored everything else?
Okay, so once everyone's on board with the medical plan?
Then comes the logistics. And this is meticulous planning.
Right. You'd have to figure out, well, everything. Which professionals do you need? Nurses, therapists? How often do they visit? How long are the visits?
Exactly. And it's not just a schedule. You have to think about the impact. What does it mean for the HaH team's workload? What about other kids in the family? Bringing a medical team into the home. It affects everyone.
The whole ecosystem.
It is. And it goes beyond the HaH team, too. You need the labs involved for tests. The pharmacists are key, getting meds ready for home use, making sure everyone knows how to use them safely. Maybe other specialists, too. The goal is building this whole patient-centered network around the home.
Now, one of the biggest differences, like you said, between hospital and home is you don't have help right down the corridor.
Exactly.
So anticipating problems, being prepared, that must be absolutely crucial for HA.
It's crucial. You have to think ahead. What are the potential medical reactions? What symptoms might pop up? How will the family, how will the HaH team respond?
Right.
It means having the right meds, the right supplies, actually in the home, ready to go. Sometimes having written protocols is really helpful, especially for parents, because often they become the first responders.
So you need to empower them. Give them the knowledge, the tools.
Precisely. So they can act confidently if something happens.
And does that also mean linking up with emergency services?
Definitely. They need to know about the patient, understand how to be contacted, because the HaH team itself isn't an emergency response unit. And you also have to plan for, the possibility of needing to go back to the hospital.
How would that work? Transportation?
Yeah, thinking about transport ahead of time. Not all ambulances are equipped for every situation. And the tricky part is you can't always predict when or if you'll need it.
So going back to Max, his situation really drives home that for many of these kids with chronic conditions, HaH isn't a short-term fix.
No, it's often a long haul. If you agree to send that baby home in December with congenital nephrotic syndrome, you're likely signing up for months, maybe even years of support.
Wow.
And that means constant adaptation. As the child grows, they start crawling, walking, gain weight, maybe start school, need therapy, want to go on holiday.
The plan has to change with them.
Constantly. Sometimes that even means collaborating with HaH teams in other places, maybe other countries, to make sure care continues seamlessly if they travel.
That's incredible.
Yeah, the key insight really is that pediatric HaH isn't just about replacing a hospital bed. It's about building the sustainable, evolving support system within the family, adapting to the child's whole developmental journey. You're basically turning the home into a flexible healthcare hub.
It sounds like an amazing option when it works.
Yeah.
But I imagine it's not always the right choice.
No.
There must be times when HaH isn't suitable.
Oh, absolutely.
Yeah.
Sometimes, sadly, the child's condition might just be too unstable, too unpredictable for home management.
Okay.
Or maybe an initial attempts didn't go well. Perhaps there were misunderstandings or mistakes were made that put the child at risk, and you cannot underestimate family exhaustion.
That must be immense.
It's incredibly demanding, providing that level of care at home 204/7. Sometimes the family just needs a break, or the hospital setting is actually less stressful for them at that point.
And it's not like it's HaH or hospital, is it? It's more of a spectrum.
Exactly. It's a continuum. Kids can move back and forth. HaH isn't a one-way street. Needs change. Situations change.
So for Max, that decision to get him home for New Year's, that was a huge turning point.
It was life-changing. For him, obviously, getting to spend those early years at home, but also for the hospital, freeing up a bed, resources, and for the HaH team, too. It pushed boundaries, showed what was possible. It really opened doors for other kids with similar complex needs down the line.
Okay, so let's fast forward those 2 weeks. Max makes it home, New Year's Eve. What did that actually look like? Because it wasn't just bringing home a baby.
No, it was basically setting up a mini ICU at home. It was a huge undertaking. He went home with, get this, 17 different medications.
17.
17. Plus an IV treatment, 2 subcutaneous treatments and 4 different pumps. 2 for the albumin, 1 for his feeding tube, 1 for subcutaneous injections.
Wow.
Plus, mountains of medical supplies, a system for sharps disposal. It was significant.
And the human support that came with him?
Just as extensive, nurses visiting every single day, doing checkups, preparing all those complex treatments. Figuring out tiny baby doses from adult meds isn't simple.
You can.
Giving injections, using nitrous oxide if needed for pain, and critically, teaching the family. Constantly teaching and supporting them.
And it wasn't just nurses.
Right. No, full team. Weekly dressing changes for his lines, regular blood tests, pediatrician visits, a dietitian involved, psychologist, physical therapist. It was the whole multidisciplinary team just operating in the home instead of the hospital.
Thinking about setting all that up, what were some of the biggest logistical challenges the team faced initially?
Well, over the years, Max was on HaH. He definitely hit bumps in the road. He had complications, fluid overload, hyperkalemia, various infections, loss of appetite, anorexia, anemia, blood clots.
Okay.
Which brings up an interesting question. Thinking about those complications, which one do you reckon would be the easiest to manage at home?
Easiest. Well, with antibiotics available at home now, maybe infection.
That's what a lot of HaH professionals thought initially when asked. It seems logical, right? We can give IV antibiotics at home. But surprisingly, the consensus often leans towards anorexia managing loss of appetite, often by using a feeding tube to make sure they get nutrition.
Really? Why is that?
Well, it can be relatively straightforward in some cases once the tube is in. But the really important takeaway is that most of these complications can potentially be managed at home. It just heavily depends on the specifics.
Okay.
How did the problem start? What's the bigger clinical picture? How prepared is everyone, the team, the family? And what are the local resources and how is care organized in that area? It's very context dependent.
Max's story just keeps highlighting how vital that venous access getting into his bloodstream was for his care.
Absolutely essential.
Continuous albumin, potential need for other drugs.
Yeah.
You need reliable access.
You do. And in pediatric HaH, we typically look at a few options. Central lines, things like ports or PICC lines. Then you have regular peripheral IVs. And sometimes even using the subcutaneous tissue under the skin for blood draws or certain meds.
For listeners maybe not familiar, a port is that little device under the skin, right? Usually the chest. And a PICC is a line going in through the arm.
Exactly. A port gives easy access to a large vein. A PICC is a thin tube, usually in the arm, that reaches a large vein near the heart. And each has pros and cons, especially with kids.
And the challenges with kids must be quite different than with adults.
Oh, hugely different. You've got children who might not understand, they might be scared, less cooperative.
Right. Procedures must be harder.
Much harder. It often requires distraction techniques, maybe even sedation, like nitrous oxide, which, as you mentioned, in France, is generally only in hospitals or HaH settings, not typically with private nurses.
And just technically.
Technically harder, too. Placing 4 Vs, choosing the right catheter size in a tiny baby, it takes specific skill.
But despite those challenges, HaH actually offers some real advantages for managing this venous access.
Definitely. We follow really strict protocols, just like in the hospital. In Paris, for example, there's a network with shared guidelines. We can offer emergency support, 241 then, if a dressing comes loose on a port or PICC.
That's a huge peace of mind for parents.
It is. There's phone support for questions. Our teams have trained pediatric staff who know how to handle these lines. We can even give meds to unlock central lines at home. And a big focus is always on pain control and preventing infections. The teams can take the time needed, make it as comfortable as possible for the child.
And beyond the purely medical stuff, managing this at home must really impact quality of life.
It's transformative. Fewer hospital trips, less waiting, less fatigue. Siblings aren't separated as much. The child stays in their own environment, which we know is so important for development.
Yeah.
And it helps parents balance work and care, which is a massive challenge when your child has complex needs.
So what if HaH isn't the right option for managing venous access? What are the alternatives?
Well, there are alternatives, but they often have downsides. Private nurses, sometimes they're hesitant. These procedures take time. The payment structure in France doesn't always encourage it, and they might lack specific pediatric training. Relying on parents for complex procedures isn't always ideal either. Blood collection centers, maybe, but availability can be an issue, and again, pediatric skills might be lacking.
So often it defaults back to the hospital.
Often, yes, which means dealing with bed shortages, more stress, more travel for the family. It's not ideal.
Let's touch on the different types again, ports, PICCs, peripheral lines. What are the main pros and cons for kids in HAH?
Okay, so port's pros: easy access once they're in, relatively painless to use. Cons: need regular maintenance, always a risk of infection, can sometimes limit activities like swimming.
Right, and PICCs.
PICCs, pros: less invasive to put in than a port. Cons: the dressing needs really careful management so the line doesn't get pulled out.
And peripheral IVs.
Simplest, least invasive, but strictly short-term and not suitable for all medications.
And complications are possible with any of them.
Absolutely. Mechanical issues, line damage. Blood clots often treatable at home, actually. And infections, which in France usually mean a trip back to the hospital for monitoring and treatment. And unfortunately, the risk of complications can be higher if the family is facing difficult social circumstances.
So how is the decision made? Which type of access is best?
It's a shared decision. The child's main doctor, the HAH team, the family, they all weigh in.
Okay.
They look at the child's specific needs, their home life, their age, their development stage. What works for a baby might not suit a preschooler.
And are there alternatives to sticking needles in veins?
There are. Subcutaneous injections under the skin are one way, but they can be painful, and not all drugs work that way. Another route is continuous enteral administration, giving meds through a feeding tube.
Okay.
That avoids needles, can be done at home, but absorption might be less predictable and there can be side effects. Looking ahead, people are exploring training parents for more things, like certain injections and using remote monitoring tech.
Okay, let's loop back to Max. 3 years of albumin, a year of dialysis. He finally gets his kidney transplant. A massive moment.
Huge.
But the journey wasn't over, was it?
Not at all. The transplant itself is major surgery, then ICU, managing rejection risk, high blood pressure. But incredibly, after about 15 days, he was stable enough to potentially go home again.
Wow, that's quick.
Relatively, yes. But his treatment plan was still intense. Daily shots to prevent clots, scar care twice a day, daily blood pressure checks, still needed tube feeding, blood tests twice a week with a special home device, a TOCA device.
Okay, that allows home blood draws.
Yes, with a small device. And critically, those daily anti-rejection meds. Absolutely vital.
So the big question again, post-transplant Max,
Okay.
HAH or no HAH?
Exactly. And the answer is, well, it depends. Again,
Always it depends.
it always depends. You have to look at how much can the family manage independently now, even with nurse support. Is Max medically stable enough for home? Does the HAH team have the capacity for these new treatments, the frequency, the duration? Is there a consistent caregiver at home?
Right. Are any treatments needed that are only available in hospital in their area, like nitrous oxide, maybe specific dressings? Sometimes families just need that transition time. They're not ready to go from intense hospital care to being totally on their own.
Especially after something as big as a transplant.
Exactly. And if there are still multiple complex needs, that coordination piece is essential. HAH can provide that.
So it's very case by case. You mentioned different scenarios, like a family already comfortable managing some things versus one where maybe the main caregiver has other major stresses.
Precisely. And if something like nitrous is needed, that often points clearly towards HAH if it's not available otherwise. And sometimes you're just not sure.
See, what do you do then?
Often the best approach is to try HAH. Get the nursing support in place, see how it goes for a few days, then reassess. At best, it keeps the family together at home.
It sounds like a constant balancing act, especially in that transition phase, which raises another question. How do you decide when to stop HAH in these complex cases? It can't go on forever. No, exactly. The idea is often that HAH acts as this timer almost, a period of intensive support to help things improve, to help wean off interventions.
Yeah.
As the child gets more stable, as the family gets more confident and skilled, you gradually reduce the HAH visits. The goal is eventual independence, stopping HAH support altogether when it's safe and appropriate.
So if we were to boil it down, what are the key ingredients for successfully turning that hospital stay into effective pediatric HAH?
I'd say it boils down to a few things. First, really translating the child's needs into a workable home plan. Second, lots of discussion, imagination, creative thinking from everyone involved. Third, flexibility and adaptation, knowing things will change. And finally, constantly questioning, what are the limits here? What's the right balance between medical care and family life at home?
It's an ongoing story.
It is. Chronic illness stories evolve, and thinking about HAH at each stage can be a powerful tool to keep kids out of hospital as much as possible.
We actually got some great questions from listeners digging into the specifics, particularly the French model. Peter from Sweden, who's involved in expanding HAH there, asked about the overall setup in France.
Great question, Peter. France has made, I think, quite good progress. We believe pediatric HAH is available in most regions. Now we've identified at least 30 teams, though getting a complete national picture is tricky.
Are there challenges?
Oh, yes. Upscaling faces resource issues, political hurdles, so implementation isn't perfectly even everywhere. You see different models. Some areas have dedicated pediatric HAH teams. Others try to integrate kids into general HAH with specialist backup.
And in a major city like Paris?
Paris has, I believe, 4 main departments managing over 100 pediatric HAH patients daily, often organized geographically, similar to how hospital teams might cover certain areas.
Okay. We also had a question about parental education. How do you support parents to become more autonomous with chronic care at home?
That's so important. It's really teamwork between the hospital and HAH. The initial teaching, what we call therapeutic education, starts in the hospital.
Right.
Then the HAH nurses continue it at home, reinforcing skills, building confidence. For some things, like certain treatments, parents might even be taught how to remove needles themselves safely.
You tailor it to the family.
Absolutely. You have to adapt, consider literacy levels, provide clear written guides if needed. It's very individualized. And the goal is always to gradually reduce HAH support as the family gains autonomy. It becomes almost like a day hospital at home, eventually phasing out.
Sarah from Australia asked about childcare assistants. In the French HAH model, what role do they play?
Yes, the auxiliaire de puériculture, or AUX. They have about a year's specialized training in basic childcare and development. In HAH, they often work alongside the nurse.
Doing what exactly?
Their key role is often providing distraction, helping keep the child calm and settled during procedures. It can make a huge difference for everyone involved, the child, the nurse trying to perform a task. They're really valuable members of the team.
Ava Ko from Switzerland wanted clarification on team structures. Are they separate hospital teams and separate HAH teams going into homes?
Yes, generally that's the model. Distinct hospital teams and distinct HAH teams who travel to provide the home care. There's coordination between them, of course.
But are there variations?
There are. In some parts of France, you might find HAH organizations that coordinate care but actually use independent primary care providers, liberal professionals, for the home visits. So the HAH body manages the case, but independent nurses or therapists deliver the care.
Interesting. And following on from that, Ava asked how HAH works with community health nurses.
Yeah, the goal is definitely not to compete. We want to collaborate. The challenge in France, honestly, can be finding primary care workers, community nurses who have the specific training and willingness to take on complex pediatric chronic care cases.
Right.
So when they are available and willing, we absolutely want to work together, define roles clearly, and make it work for the child. But finding them can be tough sometimes.
We also got a couple of questions related to applications or specific situations. One was about how does pediatric HAH compare cost-wise to a hospital stay?
In France, the data shows HAH is significantly cheaper for the healthcare system. Roughly speaking, maybe around 500 euros a day for HAH versus 1,000 euros or more for an inpatient day.
That's a big difference.
It is. But it's crucial to remember that figure doesn't capture the indirect costs for families, time off work, childcare for siblings, travel. Those aren't factored into the system cost.
Good point. Another question. Do you have experience with oncology patients needing frequent platelet transfusions at home?
Yes, absolutely. We do care for oncology patients at home, including those in palliative situations who might need platelets frequently, even up to twice a week in some cases.
And lastly, a question about giving albumin infusions at home, like Max had. How is that monitored without hospital equipment?
Right. Albumin can be given different ways. Max had it continuously 24/7, but sometimes it's shorter infusions. At home, you don't have continuous electronic monitoring like in an ICU.
How do you ensure safety?
It relies on a combination of things. Daily clinical checks by the visiting HAH nurse, regular weekly blood tests to track levels and other markers, and critically, the parents' observations. They live with the child, they know them best, and they become incredibly skilled at spotting subtle changes.
It's so clear listening to all this, especially Max's journey. Successful pediatric HAH requires just this incredible blend of medical expertise, logistical skill, adaptability, and real human connection.
Absolutely. It's complex, it's demanding, but the focus always has to be on the child and their family.
And the impact.
Yeah.
It seems profound.
It truly is. Giving these kids and their families a chance at a more normal life in their own homes surrounded by love. It makes such a difference compared to spending months or years within hospital walls.
So as we wrap up this deep dive, it really makes you think about the bigger picture, doesn't it?
Yeah.
How can we apply these ideas, this flexibility, to other parts of healthcare, maybe globally? Caring for vulnerable people in their own homes. What other big challenges could we tackle if we just shifted our perspective like this? Definitely something to mull over.